Okay, thank you and hello everybody. I'm going to speak today on high resolution CT of the lung, nodules, emphysema, and cysts. So the learning objectives are to identify patterns of small nodules, to list the differential diagnosis for each pattern, to recognize various patterns that we might see in emphysema, and to differentiate emphysema from honeycombing. We'll also distinguish cysts from emphysema and bronchiectasis, and to list the differential diagnosis for cystic lung disease. So there are various abnormal high resolution CT patterns that we might see. And we're going to concentrate today on nodular opacities and then decreased opacities. The others, increased opacity and reticulation, we won't talk about today. So as far as nodules, let's start with nodules. For small nodules, there are three primary patterns: perilymphatic, random, and centrilobular. And centrilobular can be further divided into tree and bud or without tree and bud. And also sometimes ground glass opacity is an important type of centrilobular pattern. But remember, I don't usually say the word tree and bud nodules. I'll say centrilobular nodules of tree and bud configuration or tree and bud pattern, just because I want to make it clear that tree and bud is a type of centrilobular distribution. Okay, so let's start with perilymphatic nodules. So perilymphatic as well as random nodules can be on the pleura and subpleural region. So let's start again. Perilymphatic has specific predilection. It includes pleural and subpleural, and that will also be fissural because the fissures are composed of pleura. Peribronchovascular, so around the bronchi and around the vessels. Septal, so interlobular septal, as well as the distribution tends to be multifocal and patchy. So it won't be diffuse and uniform, but it'll be multifocal and patchy. Whereas random nodules, how about random nodules? So these are randomly distributed relative to the secondary pulmonary lobule. There will be a diffuse uniform distribution, so it'll be more evenly spread. And we will also see pleural nodules because the nodules go everywhere. So there will be pleural nodules. And they're usually well-defined and cleanly marginated nodules. Now the third pattern, centrilobular nodules. Okay, so in centrilobular nodules, sometimes we see focal disease, just one area, or we'll see multifocal or sometimes more diffuse. I think multifocal is the most common distribution of centrilobular nodules. They tend to be in or near the small airways or vessels, and they usually indicate usually indicate small airways issues, but sometimes they indicate vascular disease as well. They are not on the pleura, unlike the two other patterns, which are perilymphatic and random. These are not on the pleura, and that's a critical differentiating point. There tend to be 0.5 centimeters to 1 centimeter away from the pleura. Now, that said, any person could have a couple of pleural nodules. So you just scan someone, there may be some pleural nodules, but if we see one or two pleural nodules, that may just be underlying pleural nodules, and then there's a centrilobular pattern on top of it. So keep that in mind. Just because you see one or two doesn't mean you're going to exclude centrilobular, but that shouldn't be a characteristic place. Okay, and often the centrilobular nodules are ill-defined or ground glass, and they can be tree and bud. When we see tree and bud, it usually indicates infection, although sometimes aspiration can also cause tree and bud pattern of the nodules. So let's start with this case. Now, I do have case numberings in this talk, and they don't correspond to the quiz cases that I sent, but some of the quiz cases are going to be here. Just be aware of that. Okay, so this is the first case. Do we see nodules? That's the first question I ask. And yes, we see multiple small nodules. So are there nodules on the pleura? That's the next thing I ask. And we do see multiple pleural nodules. Okay, so let's go from there. And then, okay, so this is lower down, same patient, multiple pleural nodules on the fissure as well as peripherally. So if we see pleural nodules, then if it's patchy, subpleural, and peribronchovascular, septal, then we think that it's going to be perilymphatic distribution. So this one is more patchy, subpleural, peribronchovascular. It's not diffuse. So this is the perilymphatic distribution. The most common thing is sarcoidosis. Everything else is much less common. I rarely see any of these. If I see perilymphatic distribution, at least in our population, it's almost always sarcoidosis. Silicosis is now much less common, at least in the United States it is. I don't know in India, but silicosis uncommon. Kaposi sarcoma used to be common 20 or 30 years ago, but no longer with HIV. And lymphatic spread of tumor is uncommonly seen. Okay, so we see again fissural nodules and pleural nodules, but we also see peribronchovascular, meaning along the vessels and the bronchi. You see all the nodularity here. So this is a classic perilymphatic pattern. Notice it's patchy, it's not diffuse and uniform. So this is a patient with sarcoidosis. As I said, that's the most common cause of this pattern. Another patient, look at the multiple nodules here. Many of them are along the fissures, bilaterally. And then we also see the peribronchovascular nodularity, look at the vessels here and the bronchi. So another patient with this patchy nodularity, this is also perilymphatic, and another patient with sarcoidosis. And then a third patient, I think I have another image here. Yes, we can see a few nodules here. This is a little bit more equivocal, but when I see those nodules, I immediately want to think about sarcoidosis as a possibility. Okay, so that's just with that, I think sarcoidosis, but other things can do that, like metastasis. Okay, and then this is also, these are a little bit larger nodules as we can see, but there are fissural nodules and some peribronchovascular. But notice these bigger conglomerate nodules, those are, some people have described those as flame shaped, like a fire flame shape. And this is Kaposi sarcoma, but again, this is uncommonly seen. Okay, let's move to a different patient. This is another case. And again, these don't correspond to the quiz cases, these numbers. So look at this. There are multiple nodules. Yes. Are there pleural nodules? That's the next question I ask. And we can see nodules along the fissures as well as in the periphery here. So there are definitely pleural nodules. Notice this one is more uniform. There's no predilection to the peribronchovascular bundles. There's no predilection to the pleura and fissures. It's uniform and diffuse. So this is a different pattern altogether. So since it's diffuse and uniform, there's no predominance, we are thinking about random nodules. And with random distribution, we will think about miliary types of disease, such as miliary tuberculosis, fungal infections such as histoplasmosis or coccidomycosis, which are less common, and then miliary metastases, such as from a number of different diseases cause this miliary pattern of metastasis, including sometimes melanoma, choriocarcinoma, breast cancer, renal cell carcinoma. So those are some of the things to consider. No, okay, so this is the diffuse random pattern. So this one happens to have miliary tuberculosis. Miliary TB is usually, it's usually a primary TB that can do this. And it's highly infectious and the patients tend to be very sick. There's another patient. So the first one I showed you, this is a more extreme example of so many nodules. This next patient also has nodules, but not quite the same number. We see some nodules on the fissure. So I always ask, are there fissural nodules? Because if there are not, then I'm leaning towards centrilobular. But we see multiple nodules here, not just one or two, but multiple nodules on the fissures. And they're randomly distributed throughout. They're not particularly on the parabronchovascular bundle. So miliary tuberculosis again. Okay, let's move to a different patient here. This case, we see multiple nodules. Are there fissural nodules? Well, I don't see nodules on the pleura. There's a little bit of bumpiness, but I wouldn't call those nodules, especially they're not the size of these. And are there any on the periphery? Well, there's like this one, but as I said, any patient can have one or two nodules. That's okay, but the vast majority are away from the pleura, 1 to 2 centimeters, sorry, 0.5 to 1 centimeters away from the pleura, half a centimeter to a centimeter away. So this pattern is different. This one is no pleural nodules. So this is the centrilobular distribution. And if there is no tree and bud pattern, so these are nice round nodules. So I would not call these tree and bud. Now, I want to clarify, some people refer to tree and bud, meaning this whole pattern is like a tree. And that's not the case. Tree and bud is an individual nodule. Look at it. If it's budding and branching, then that's tree and bud. If they're not, then it's not tree and bud. And there may be 1 or 2 tree and bud, but I'm not sure. We should use a high threshold. And if we're not sure, we'll just say, no, it's not tree and bud, it's just centrilobular nodules. It has to be clear cut and unequivocal tree and bud to say it. So without tree and bud, the most common disease is bronchiolar disease, and those are listed here. Endobronchial infections, hypersensitivity pneumonitis can do this, and vasculitis. So those are some of the things to consider without tree and bud. So this patient has these no tree and bud nodules, and this one happens to be an infection in endobronchial pneumonia. So what do I mean by that? It's infection that's spread into the bronchi. So some people call this infectious bronchiolitis. That's another term that we might hear, or bronchopneumonia. And what are the organisms that can do this? Bacterial pneumonia is often the organism that we're thinking of. Endobronchial tuberculosis, which is highly infectious and the patients are very sick. In our patient population, we have a large stem cell transplant patient population in our center and in our city because our institution was the one that pioneered stem cell transplant and bone marrow transplants. So we have many patients who have immunocompromised, and we have to think about fungal infection in them, like aspergillosis. And then the less common thing is atypical Mycobacterium, Mycobacterium avium complex, MAC. Okay, so this is another patient. Notice that there are multiple nodules. Look at the periphery. There's actually a dark band around the periphery indicating there are no subpleural nodules. So there are no pleural nodules here. So this is also centrilobular nodules, but look at the individual nodules. Okay, look at that, for example, look at this nodule. This has a different pattern, and this isn't questionable. I think there's quite a few that are clearly branching. So this is centrilobular distribution, and this is tree and bud. And tree and bud nodules in the centrilobular distribution usually indicate infections, and the same infections, bronchopneumonia, which is bacterial, atypical or typical, atypical Mycobacterium tuberculosis, and fungal infection. Those are the 4 that we consider. And it depends on the patient population, it depends on the demographics and the patient's history. Okay, so this is a tree and bud. So again, I don't want this to be misleading and think about Well, these are the vessels, and then the nodules are sitting in this distribution. That's actually a centrilobular distribution, but it's actually the budding itself. And this is actually maybe a better thought. So there's this game called Jacks, a child's game. And this is what a tree and bud nodule looks like, something like this. Maybe not this many branches, but if there are a few branches, that's what the tree and bud nodules look like. So I like this particular way of thinking about them. So again, think about those jacks sitting here, for example, or this one. So these are the branching nodules. So as I said, it's usually infection. This is bronchopneumonia, which is bacterial. Okay. Yes. And then how about this one? So remember I said centrilobular nodules can be diffuse, but they're often patchy and multifocal. This patient has multifocal disease out here and, for example, there, and there were other locations as well. We can see the branching pattern here in the individual nodules. These are tree and bud centrilobular nodules. There are also conglomerate nodules here. This is characteristic of atypical mycobacterium. You could potentially see this in TB too. In our institution, in the United States, we don't have very many patients. Could you please mute if you are in the audience? I'm hearing some background noise. So in our institution, we don't hear very much in terms of we don't see very much TB in the United States, but we see some patients. But this is atypical mycobacterium, but TB can look the same. A different patient, this is a prone image, and you can see more extensive involvement with these nodules. They're branching. This is tree and bud. This is also another patient with Mycobacterium avium complex. One of the things about MAC, or atypical mycobacterium, it's frequently anterior distribution, and typically in patients who are over the age of 50. So middle-aged to older individuals, and often anterior distribution. I'm showing you here posterior, but we might see, for example, lingular, right middle lobe, and anterior upper lobe distribution. That's characteristic. And we'll also see bronchiectasis, which we see a little bit of here, mucus plugging, the conglomerate nodules I showed you, and sometimes necrotic lymphadenopathy. Okay, this is the next patient. So again, multiple nodules. And then we see a lot of nodules here. Look at the periphery, it's spared. I don't see the same nodules on the pleura. Okay, so these are the same pattern of centrilobular nodules, but is there tree and bud? No, I don't see any branching. But are these solid nodules? That's something we have to think about. Okay, so centrilobular distribution, if they're ground glass nodules, then this is what the differential diagnosis is. Frequently hypersensitivity pneumonitis, respiratory bronchiolitis, also known as RBILD, respiratory bronchiolitis interstitial lung disease. That is related to smoking. That's one of the smoking-related lung diseases. And then plexiform arteriopathy, which occurs in pulmonary hypertension, also known as plexiform angiopathy. So that's a vascular cause, and the other two are airways causes of centrilobular nodules, ground glass opacity. Okay, this is a patient who has hypersensitivity pneumonitis. This is the subacute hypersensitivity pneumonitis. In subacute HP, we can think about a number of different patterns. It's usually ground glass opacity. Sometimes the pattern is like this. This is a less common pattern, but it can be centrilobular. It can be patchy ground glass opacity, or it can be diffuse. And we might also see what's called the head cheese sign, which is ground glass opacity plus mosaic attenuation at the same time. Okay, with that, so I'm going to turn now to decreased lung opacity, and primarily you're going to be talking about emphysema and cysts. So if we see black holes, meaning pure black, that's focal lung destruction. And that occurs in emphysema or cystic air spaces because there's lung destruction there. If you see decreased opacity without black holes, that is essentially mosaic attenuation or mosaic perfusion. I'm not going to be concentrating, I'm not going to be spending time today on mosaic attenuation. I'm going to be spending the time on the black holes. They have to be pure black, meaning it's just air. It's not lung tissue. So there's destruction of lung. Okay, so what causes these black holes? Well, honeycombing occurs in fibrosis, emphysema, cystic bronchiectasis, cysts, and nematoceles. These are some of the things that we can consider when we're talking about black holes. Okay, so let's look at this patient. This is the next patient. Notice in the periphery especially, there are these dark areas. And there's only one layer in most of this area, although here there's a second layer, but generally one or maybe two layers of peripheral black holes. So that's lung destruction. So if you see subpleural, meaning peripheral black holes, then if it's a single layer, think paraseptal emphysema. If it is multiple layers, think honeycombing. So that's one way we differentiate. Single layer paraseptal emphysema, multiple layers, especially 3 or more layers, think honeycombing. Yes, and I feel that somebody is not muted. Can you please check your computer to make sure that you're muting?
Dr. Gautham, just a moment, please. Can I reclaim your, I'll just a moment, please. Just a moment.
Please.
Go ahead, sir. Please go ahead, sir. Sorry.
Okay, thank you. So remember, single layer paraseptal emphysema, if it's peripheral subpleural, if it's multiple layers, 3 layers usually, then think about honeycombing. Okay, so this one has a single layer and in one place 2 layers. So this is most likely paraseptal emphysema. Now we often think of emphysema as having no walls, no perceptible walls. Here we definitely see perceptible walls. That is frequent in paraseptal emphysema. We will usually see the walls in paraseptal emphysema, but not in centrilobular emphysema. So I just do want to point out here, this patient also has centrilobular emphysema, which I ignored, but notice that there are no walls or very faint or just partial walls, but most of the areas don't have perceptible walls, whereas the peripheral ones, paraseptal emphysema does have perceptible walls. And again, how do we know that's not honeycombing? Because there's only 1 layer or maybe 2. Okay, let's compare it to this patient who has also peripheral black holes with perceptible walls. And notice here, there's only 1 layer here, but there are multiple layers away from the pleura on this side. So these are large. Sometimes we see these as very small, small like this or even smaller. So this is multiple layers away. So think about that. That's going to be honeycombing. So this is a patient who has honeycombing with idiopathic pulmonary fibrosis. So these are honeycombs, and this is the pattern that we might see in honeycombing. So remember, multiple layers. There won't be 10 layers like this, but usually 3 or more. If it's 2 layers, we usually do not call it honeycombing. And the reason that we use a high threshold for honeycombing is that honeycombing essentially indicates end-stage lung disease, end-stage fibrosis. So we may not biopsy, the patient may not be a candidate for some of the newer treatments. So use a high threshold. Otherwise, you're essentially saying they're not going to be a candidate. We're not giving them the benefit of the doubt. So that's why we say 3 layers for most patients, generally in most scans. Okay, so there's extensive fibrosis and lung destruction associated with this. These are reticular and cystic with 0.5 to 1 centimeter size. And I'm not going to talk about all of the different issues. This is all related to fibrosis, but remember 3 or more layers is typically honeycombing in the setting of fibrosis. So this is another example of peripheral cystic spaces with perceptible walls. Is this paraseptal emphysema? Is this honeycombing? Notice there are quite a few places with multiple layers away from the pleura. This is honeycombing, so multiple layers here. Honeycombing, this is not paraseptal emphysema, although this may be if I just saw this by itself, or this may be coexisting, but there's quite a bit of honeycombing. So another patient with fibrosis and idiopathic pulmonary fibrosis and honeycombing. Let's talk about this one now, this patient. Look at the black holes. They're primarily in the center, and we have to think about whether we can see walls here or not. Okay, so if they're intraparenchymal black holes of these dark spaces, think about whether they're visible or perceptible walls or not. Okay, so that's how we differentiate. So this patient, I feel, does not have visible walls. So that's what we see in centrilobular emphysema. So you see that. So there may be one or two areas like this. I think that's just septal thickening, though most of the areas do not have visible walls. That's the primary characteristic feature here. So this is emphysema, and that's a really important differentiating point between emphysema versus cysts. So emphysema is most often has upper lobe predominance. So that's most common. And when we see upper lobe predominance, it's usually, but not always, centrilobular, which is smoking related. Sometimes we see panlobular upper lobe predominant emphysema, and that is called, often called vanishing lung syndrome, where they're huge bulli that are destroying the lung. But more commonly, it's centrilobular. Okay, and smoking related. Now, lower lobe predominance is less common, and that's often panlobular emphysema. This can be related to smoking, but often we have to think about other diseases such as alpha-1 antitrypsin deficiency and Ritalin lung, in which patients will take Ritalin medication and they crunch it into small pieces and then inject it intravenously. So that destroys the lung in the lower lobe, primarily in the lower lobes, because that's where the blood supply, the greater blood supply is. So again, lower lobe predominant is often panlobular emphysema, less common than smoking-related upper lobe involvement. So this is from one of my colleagues, Sudhakar Pipavath, who has published this case from our institution. We can see this upper lobe predominant emphysema. Notice that there's small areas. As we come down, it's less prominent. This is a patient who has centrilobular emphysema, and this is the same patient. So notice that most of the disease is in the upper lobes. It's just small areas. It's not destroying extensive areas. And they start within the central part of the secondary pulmonary lobule, near the airway and near the vessel and airway in the center. Okay, notice a different patient here. As we come down, notice these large areas of lung destruction here. This is lower lobe predominant emphysema, and they're large areas. This isn't centrilobular. This is the panlobular pattern. Notice here how big the destruction is and lower lobe predominance. So this was a patient who has panlobular emphysema. And again, the most common things to think about are alpha-1 antitrypsin deficiency, Ritalin lung, and then other things. Sometimes smoking does this as well. It's just uncommon. Okay, so just to compare, this was the patient we saw earlier with centrilobular emphysema. And this is paraseptal emphysema. Notice that this is peripheral with perceptible walls, the centrilobular wall, excuse me. Centrilobular emphysema has generally no perceptible walls. And you can see in this patient, centrilobular emphysema as well. So that's something that we differentiate. Let's move on and talk about this patient now. So what do we have in this particular individual? We have multiple black holes. Notice that they're not subpleural predominantly. There's more central intraparenchymal black holes. And do they have perceptible walls? I would say most of them do, like this one and this one and this one. And even the smaller ones do. So these are not centrilobular emphysema. These have visible walls. So think about cysts or pneumatoceles or cystic bronchiectasis. So pneumatoceles are typically post-traumatic or post-infectious. And then we have cysts. And sometimes we can't tell the difference between pneumatoceles and cysts. They may look the same. And then cystic bronchiectasis. Okay, so with cysts, lymphangioliomyomatosis tends to have uniform, relatively smooth and uniform cysts. Langerhans cell histiocytosis tends to present with cysts in the later stage of disease with bizarrely shaped cysts. So they're irregular and bizarre shaped. Okay, so this patient has uniform cysts. And they don't have to be exactly the same, but they're relatively round. This is what we mean by uniform, relatively round cysts. And they don't have to be exactly the same size. So this is lymphangioliomyomatosis. It's characteristic. This is a rare disease. And this cystic lung disease is almost exclusively in women, younger women generally, from age 20 to 50 is when they usually present. And it could be quite debilitating. This is a severe example, and patients may be candidates for lung transplant when it's this severe. And compare that with this particular patient. This patient also has intraparenchymal black holes. So these are cysts or cysts, pneumatoceles in that category. And are these uniform? Well, first of all, they have perceptible walls. Okay, and are they uniform or are they bizarrely shaped? Look at this one, for example. Look at this. I would not say that these are uniform and round. So when they're not uniform and round, so visible walls, we think cysts, but not uniform and round, think Langerhans cell histiocytosis. This is another smoking-related lung disease in adults. It also tends to present initially with nodules, and then the nodules become cystic, and then these bizarrely shaped cysts develop. And this can also be debilitating when it becomes this severe, if it's not controlled. And it's related to smoking. Non-smokers don't get this. Okay, so compare that with the lamb patient we saw earlier, who has these rounder uniform cysts, and these are the more bizarrely shaped cysts. Okay. And then compare it with centrilobular emphysema. We don't see the perceptible walls here. There are no visible walls, or very, very little and faint. That's not a predominant feature. The prior patients both have visible walls. Okay. Now let's look at this patient. This patient also has these cystic structures with the visible walls. And there's also something else going on here, pneumothorax and some ground glass opacity, patchy ground glass opacity. So what are we thinking about here? When we see this cysts, the differential diagnosis includes cysts, but it also includes pneumatoceles. And that's what this patient has. We may not be able to differentiate them, as I said. It might not be possible to tell them apart. But based on the history and the other findings, we may be able to, because the patient has ground glass opacity. They have pneumocystis pneumonia, and they have had cysts develop. And often these may occur in the past, and then we have the pneumocystis pneumonia. And a finding that's characteristic of this type of pneumonia, doesn't happen often and occurs occasionally, is a pneumothorax, because a cyst can rupture into the pleura and pneumothorax can develop. So a patient with pneumocystis pneumonia, and again, this is associated with HIV. It is not that common nowadays because HIV is much better controlled in many places. I would say though, if you have a patient who's immunocompromised due to any reason, such as neutropenia, bone marrow transplant, stem cell transplant, it could be pneumocystis pneumonia when you see ground glass opacity. The differential for ground glass opacity is edema, pneumocystis pneumonia, CMV, or other viral pneumonias in an immunocompromised individual. And COVID can do that as well. So pneumocystis pneumonia was first described in leukemia patients, and we don't associate that commonly with other than HIV, but remember it can occur. And this patient developed cysts as well. But if I just saw this, it could be lymphangioliomyomatosis, LAM. It could be that just as well. But with the ground glass opacity, the history, and the pneumothorax, I'm not thinking LAM. And this was a male patient. LAM occurs almost exclusively in women. There has been at least one patient, maybe two patients in case reports who are male, who've been diagnosed with LAM or LAM type disease. In tuberous sclerosis, there can be a form of LAM, of lymphangioliomyomatosis. Tuberous sclerosis usually occurs in males more commonly, but when we see the lung disease that looks like LAM, that is almost always in women with TS, with tuberous sclerosis. So, but there have been one or two men who have been described with that appearance. Okay. So as far as differentiating bronchiectasis from cystic lung disease, I'm not going to spend a lot of time on this. I think this is pretty straightforward. Just page through the images and see if they connect. This one, some of these are branching. I'm not going to page through them, but look how much bronchiectasis there is seen longitudinally. And this is a patient with cystic fibrosis. You can also see mosaic attenuation here with the whiter areas and the darker areas, more dense and more lucid areas. Different patient, mosaic attenuation, look how cleanly defined the margins are between the denser areas and the darker areas or more lucid areas. Clearly mosaic attenuation and marked thickening of bronchi, mucus plugging, severe bronchiectasis in cystic fibrosis. And you just page through it. Oops. Okay, so I'm going to wrap up now. So the take-home points are, so first of all, use your pattern of nodules to determine your differential diagnosis. So if we have perilymphatic nodules, including the fissures and bronchi, then think about sarcoidosis. Random nodules are more uniform. They do include the pleura, but think there about miliary disease, miliary TB, histoplasmosis, and also miliary metastasis. And then think about centrilobular nodules. There typically aren't on the feature of fissures. These are usually going to give us something like infection, but the differential diagnosis for centrilobular nodules includes, if they're ground glass, think about hypersensitive pneumonitis, think about vasculitis, about plexiform arteriopathy, and respiratory bronchiolitis with ground glass. Otherwise, think infections, bronchopneumonia, which is bacterial, tuberculosis, atypical mycobacterium, and fungus. Emphysema. So centrilobular emphysema is more common, upper lobe is more common, and this is related to smoking. Whereas panlobular emphysema is sometimes related to smoking, but is usually lower lobe. And when we think about lower lobe disease, remember to discuss alpha-1 antitrypsin deficiency as well as Ritalin lung. And Ritalin, for those, I don't know if they use that name in India, but it's methylphenidate, which is used primarily nowadays for ADHD. And people use it inappropriately with IV injection. Some people. Okay, so So when we're differentiating emphysema from other things, so think about emphysema versus honeycombing. So paraseptal emphysema is usually one layer, sometimes a second layer will be seen, but usually just one layer. Honeycombing usually should have 3 layers. So that's how we should differentiate paraseptal emphysema from honeycombing. And this is really important in the setting of fibrosis, because if we say it's honeycombing, that is end-stage lung disease. And then differentiating emphysema from cysts, centrilobular emphysema. So this is centrilobular. Centrilobular emphysema has no perceptible walls. Cysts should have perceptible walls. And then the last thing is when we're differentiating cysts, when we're looking at cysts, remember Lamb has more uniform cysts, and Langerhans cell histiocytosis has more bizarrely shaped cysts. It's smoking related. Lamb is almost exclusively in younger women. Okay, and thank you very much for your attention. And at this point, I would either take questions or I can go over the quiz cases. So please let me know.
Please go over the quiz cases, sir.
Okay. We'll pull those up. And as I have showed some of these already, so okay. So this is case 1. And how do we do this? Do we have people put in the box, or should I ask questions?
They will write answers in the chat box, sir.
Yeah, okay, so first tell me what the pattern is here.
Request all participants to, please start writing the answer in the chat box, please.
Yeah, good. So we can see there are multiple small nodules. They include the periphery, they include fissures. We can see them along the peribronchovascular bundle. So this is perilymphatic and the most likely diagnosis. Yeah, so this is characteristic of sarcoidosis. It doesn't have to be, but I actually, when I interpret these images, I will just say consistent with sarcoidosis and leave it at that. Or I will say likely represent sarcoidosis, and that's all I will say. I will not give a differential diagnosis. I did see one answer that talked about tuberculosis. This is actually not characteristic of tuberculosis, and these aren't tree and bud. So remember, tree and bud pattern can only be talked about in centrilobular nodules. So we see multiple nodules on the periphery as well as on the fissures. Maybe we can go back to the prior slide here on the fissures. So these are not tree and bud. This is fissural nodules. It can't be centrilobular. And given the patchiness and predominance on the fissures and in the peribronchovascular bundles, this is perilymphatic. TB doesn't typically have that pattern. At least, in India, you see a lot more patients with TB, so you may see exceptional situations where it occasionally occurs, but I've never seen that or even thought about that for TB. Now, how about this? The pattern, so what's the differential? So the pattern is here is first of, okay, so I'm sorry, first give me the pattern. Okay, yeah, this is diffuse nodular, and that's called random pattern, as many of you have said, and this is what miliary disease looks like. Now, what's the differential? Miliary TB, anything else? So metastasis, I think thyroid cancer is a good one. I didn't mention that one earlier. TB metastasis, and then fungal infections, miliary spread of fungus like histoplasmosis and coccidiomycosis. I would also say that, so this is diffuse and nodular, but the best description is random pattern of nodules. Okay, so what if we happen, sometimes the residents will interpret a case and there are 5 or 8 nodules in the patient, like here, 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 here. And then they say these are random nodules. Well, they're actually not. When you see that pattern, even though they do seem random, that pattern is not called random. Those are just scattered nodules. So say scattered if they're just a few nodules here and there. Random pattern means a large number like this, or maybe not quite this many, but almost a huge number like this. Okay, what's the pattern here? Good. So thank you for participating. I always feel in confidence. Sometimes people don't want to participate because there's always this fear of getting it wrong. But that's the whole purpose. If I only showed you cases that everyone would get right, there's really no benefit. You're not going to learn anything. So you have to push yourself a little bit and sometimes be wrong, and that's okay. So first of all, do you see multiple nodules? I see multiple nodules here. So that's the first thing I think about. And then I go into the patterns. So this is centrilobular pattern. So notice the periphery is spared. It's actually not subpleural. The periphery is almost completely spared. There's actually a dark line around it because the nodules come right up to it and then spare the edge. So this is not subpleural, it's not, so it can't be random, it can't be perilymphatic. This is centrilobular, but it doesn't look like some of the centrilobular nodules because they're ill-defined and ground glass. So these are centrilobular nodules of ground glass opacity. Once you get those two together, so I saw several people say ground glass, some people said centrilobular nodules, and some said centrilobular nodules with ground glass. So I would like to see both together, although I didn't ask that particular question, but when you're thinking about it, think about say both together. Once you say that and put that in your report, then the differential diagnosis is easy. The most common things, depending on the history, hypersensitivity pneumonitis, what else is in the differential diagnosis? So I saw, yeah, subacute HP. I saw a number of people say that. HP. What else is in the differential for these? It is ground glass opacity, but we have to think specifically it is centrilobular. So respiratory bronchiolitis, good, or also known as RBILD. Diffuse alveolar damage sometimes, but I think more commonly it's something like diffuse alveolar hemorrhage, yes. Okay, so let's talk about hemorrhage. So the most common things, let's talk about them first. Hypersensitive pneumonitis, respiratory bronchiolitis, also known as RBILD, and then plexiform angiopathy or plexiform arteriopathy, which is related to pulmonary hypertension. So those are the most common. So hemorrhage can do this too in the setting of vasculitis. I don't think I would use the term diffuse alveolar hemorrhage there, but it is, well, let me take that back. This is multifocal hemorrhage of small vessels. It can be multifocal hemorrhage of small vessels in the setting of vasculitis. Okay, good. And this patient had hypersensitive pneumonitis. How about this one? So what is the pattern of centrilobular nodules here? Absolutely. Good. It is centrilobular, but then the sub-pattern is tree and bud. I don't actually, I see people say quite frequently in my institution, they'll say they are tree and bud nodules. So our chest CTs are, the high resolution CTs all read by the chest radiology group. We have 7 or 8 people. And sometimes we see, sometimes if there's a chest, abdomen, pelvis that's not a high resolution CT, then that will be read by abdominal imaging. And they sometimes use the terminology tree and bud nodules. And they'll call any centrilobular nodules tree and bud nodules, which, as I said, is incorrect. And then I start seeing residents say tree and bud nodules, but I won't let them say that. I insist that they say centrilobular nodules with the tree and bud pattern. And the reason I want them to say that is I want them to remember it's centrilobular for the differential diagnosis. So this is most likely an infection. It's the vast majority are infections, bacterial infection, fungal, TB, and atypical mycobacterium MAC, for example. I would say occasionally aspiration can do this. If the patient aspirates and you just see a few posterior centrilobular nodules, that could be related to aspiration. Usually they don't have the tree and bud configuration, but occasionally they do. Okay, as far as lymphangitic carcinomatosis, that's actually a perilymphatic pattern. It does not look like this, and we should not call this lymphangitic carcinomatosis. But I would say, I'm glad somebody brought that up, because I would say that rarely, and this is additional information that it goes way beyond the basics. Rarely tumors can spread this way. So lung cancer can spread endobronchially, and it can look like this. And sometimes adenocarcinoma spectrum lesions can do this, and sometimes lung cancer can metastasize endobronchially. So rarely this would be lung cancer, and I would only bring that up if the patient has, for example, bronchorrhea as the history, which is a lot of mucus production from the bronchus that occurs in adenocarcinoma in some patients, or if this is being treated and multiple, they do a bronchoscopy and they don't get any infectious organism, or they treat, it doesn't go away for a few months, then we have, or it's getting worse, then we have to think about endobronchial metastasis. Okay, good. Good. And lipidic is usually also not so much like this, but that also typically has the perilymphatic distribution. Okay, how about this one? We see the peripheral opacity, peripheral black holes. Good. And how about the central holes here? Are those paraseptal emphysema too? What are the central ones like this? Are those cysts? Yeah, so centrilobular emphysema, I might not call it mixed type emphysema because centrilobular emphysema is typically smoking related. And I didn't talk about this in great detail, but the etiology of paraseptal emphysema isn't always clear. It can be seen in non-smokers and it's not always clear. So we usually just say centrilobular and paraseptal emphysema. We just name both of them when we see this. Good. And then this one. So what are some features here? We see these peripheral cysts. How are we going to characterize them? Yeah, so I'm actually asking for findings as opposed to the diagnosis itself, which I think you are all able to get, which is great. I'm glad that you have gotten the diagnosis here. But what are some of the findings here? What makes you think honeycombing? Multiple layers, yes. So I think that's characteristic. And we see the black holes plus the reticulation. So when I say black holes, that's just a way of me describing it. That's not the official term that we use. We say cystic air spaces in peripheral cystic air spaces with excuse me, with multiple layers. But that's if I'm describing it. But in my report, I will usually just say there's honeycombing at the left base, or the honeycombing in the left lung and the periphery, and in the right lower lobe. I won't actually describe these as cystic air spaces with multiple layers. That's too much detail to go into in a report. Good. And remember, IPF, idiopathic pulmonary fibrosis, has a poor prognosis. About the 5-year survival is very bad. It's about 90 to 95% patients die within 5 years. It's actually closer to 95%. So the 5-year survival is only 5%. If we call honeycombing, we're essentially not going to do anything other than we could do a lung transplant for them. But if we say no honeycombing, then we could potentially treat to try to slow down the progression of disease. Okay. So I didn't talk about that in great detail, but just use a high threshold. I want to emphasize that. How about this one? I think this one is straightforward. You can just tell me the diagnosis. Good. So this is centrilobular emphysema, absolutely. No perceptible walls. How about this one? Is this centrilobular emphysema or something else? Yeah, okay, good. So these are rounder cysts, more uniform. And again, by uniform, we don't necessarily mean they all have to be the same size and look exactly alike, but they're relatively round. That's what we mean by uniform, similar shapes. So this is a patient with cystic lung disease, and LAM is one. Cystic lung disease is rare, but LAM is one of the things that we talk about. Sometimes also LIP can cause cystic lung disease. There are a number of other cystic lung diseases that I didn't go into great detail for the sake of time. But the next one, I think people are already giving the diagnosis here. These are bizarrely shaped cysts. A common one to think about is as you're saying, Langerhans cell histiocytosis. Good. So, and then the last one, I don't know if you thought about the diagnosis before the talk today, but this one is rare nowadays. Do you see pneumocystis pneumonia frequently in India now, or is it rare? You can just type in the chat box if you think it's relatively frequent in HIV patients, or is it rare? Yeah, with therapy, most people are getting treatment nowadays in the United States with therapies like heart therapy and others, so it's rare. And I guess it depends on access to care. If they don't have good access to care, then they're not going to get therapy and they're more likely to get disease like this. Good. So, yeah, so it's a frequent, but not this pattern. Can you say what pattern? Because the most common pattern of pneumocystis is ground glass opacity with no other findings. Sorry. Yeah, so can you just type what patterns you see in PCP, in PJP? Okay, yeah, the ground glass pattern, that's the most common. This is actually an uncommon pattern of pneumocystis. It's usually just ground glass. And then I see something in this case one sarcoidosis. Someone's talking in the background. Can you please mute?
Can you please?
Okay, so there's case 1 sarcoidosis versus lymphangitic. Yeah, I see LCH versus cystic. Okay, so there's just a question here. So somebody asked a question, LCH versus cystic. I can't read that. Yeah, okay. So I think I'll just answer the question privately. But thank you so much for your attention, and I'd be happy to answer any questions or to discuss further.
Thank you very much, sir. That was one of the most, most sought after lectures, probably what we heard today from you. It was fantastic, and really pattern-based approach was, I can't explain it anything better than it. One of the best lectures we ever heard about these lesions.
Oh,
I
well,
hope
thank you.
Kavita and Ishwar also will share their thoughts, please. Kavita and Ishwar.
Yeah, thank you, Dr. Gautham. That was indeed excellent. You have made it really simple. That's the whole crux of the thing. You keep seeing these things day in and day out, but the pattern was really good. I think everybody really enjoyed the presentation. I
Thank
think
you.
most of the things you have answered, what were raised in